Thank you very much for the kind words of introduction. So let's get on with the topic, primary care and diabetes. So that's where the whole focus is on at the moment, and the Ministry of Health is also working on it. I think my previous speaker showed the data, so I'll skip these slides. Sri Lanka and India, Southeast Asia is becoming the hotbed of diabetes, basically. 537 million, and the expected rise in our region, you can see, is 68%. Of course, Africa, there is an increase, but other areas, it's about 20, it's less, 13% in Europe, right? And the prevalence of diabetes, this is from Dr. Katulanda's study in 2007, was 10.4 island-wide, 18.6 in the Western province, right? This is adults over 18 at that time. Then we did a study around the National Hospital, pre-COVID, 2017-18. The prevalence of diabetes was 27.1, right? Huge rise. The cities, the urban areas, but this is small. This is not representative of the whole country, right? Hypertension is even higher, and the national average in 2007 was 10.3. So this is the STEP survey by the Ministry of Health and the WHO. 2021 showed a 14.6 national prevalence, but having worked in our clinics, we can't agree with the number because there is another study by a university group which shows that it's almost 20%. Maybe there was a difference in the way they checked, because that study is actually superior because they have done the HbA1cs and a lot of testing. This was done with the glucometer. So there is a disparity, but by any means the numbers are rising. And the Western province, in that other study, it was above 30%. Almost 1 in 3 were diabetic adults. And the dysglycemia, pre-diabetes and diabetes, was like 50%. So it's a staggering number. So don't worry about the exact number until we sort out the situation. By all means, we can say we are going to face a huge, what shall I say, a tsunami of diabetes coming our way, right? So this is going to, it's not just the sugars going up, it's the pump, pipes, and the filter. Your heart, cardiovascular, blood vessels, and the kidneys. All these things are going to hit at us if you don't do something fast, soon, and effective. So South Asian phenotype, our genes are the elusive thrifty gene, what we call as the tendency to collect visceral fat, even with a lower BMI. All these studies have shown that compared to the Caucasian population, the complications in our patients will be more in all the micro and the macrovascular complications. This was done looking at yearly expenditure for managing the complications, and if you take the 10-year cost, we can sort of build a highway every year. And that's a staggering cost. I don't know whether we can sustain this much of cost for treating the complications of diabetes. So ADA also says, I think Dr. Reddy also mentioned, you can't be glucocentric. You have to work, it's the reducing multiple risk factors, especially the cardiovascular risk. So reducing the cardiovascular risk of our patients is of paramount importance when you're treating diabetes, because 65% of our diabetics will die of a cardiovascular disease. They don't die of hyperglycemia, only very rarely, very few, right? So the cause of death will be something else. So you have to tackle the lipids, blood pressure, smoking, holistic approach, I think the previous speaker very rightly mentioned. So even the management, these are very busy slide, the ADA and the ESD latest management guidelines have become very complicated compared to the previous one, where it's patient-centered, holistic, patient-centered management plan we have to do. So you have to understand your patient, know the micro and the macrovascular complications, and then give a plan and and the goals. HbA1c, fasting, everything will change according to the patient's needs and the situation. So the proven models, how do we tackle this? Now the primary care is my focus here. That a lot can be done in primary care level. That's what I'm trying to show. So before this happen, we should try diabetes prevention. We know that 50% of our diabetics are either undiagnosed, and there is an equal proportion who are pre-diabetic, blood sugars between 100 to 125. So these are ideal population where we can intervene at the primary care level and treat these people. So the diabetes prevention study, I don't have the time to go through the details, but lifestyle changes, exercise, good diet, weight reduction, and simple medications like statins and metformin can prevent lots of problems in these patients. You have to catch them early and treat. So screening, early detection, that's what we are trying to do in the primary care level. Why early detection? The theory of metabolic memory and the legacy effect. If the sugars were high within the first 5 years, whatever you do after that, the complications will be more. So I don't have the time to explain that, but remember these two terms, metabolic memory and the legacy effect. And we should even go for reversal. I think Prasad in his speech suggested the direct study. This was done entirely in the primary care setting, low-calorie diet. So what you need is a dietitian and a good follow-up, and encourage the patients, young people, if they are overweight or obese, if they lose 10% of their body weight and stick to like 850 kilocalorie diet for about 2-3 months, even 2 months, 46% were able to reverse their diabetes. To do that, we have a very good structure. I apologize to our visitors. These are our government, most of our patients will be coming to the government sector, starting from the primary medical care medical units, PMCUs, right up to the teaching hospital. We have a good structure. We have clinics at different levels with different levels of expertise. It's a matter of, I feel, fine-tuning, having the processors, the referral and a back referral system, and a smooth flow of patients from one level to the other, with a single identification. That's what we are trying to do, where when they come from the tertiary care level to the peripheral unit, primary care unit, the record should be seamless. That's what we are trying to do. Otherwise, it's a big problem when there is a gap in the investigations, and we can't have a harmonious diabetes care for these patients. So I'm not going to give the definition analysis, just for the completion I have put it there. And we have, all of you know, we have a good primary health care service in our country, and at different levels up to the district hospital levels, then MOH and field clinic centers. We have a lot of staff, public health midwives and the public health nurses, and then a good referral system, at least to the OPDs. And 30% of the current health expenditure is spent in primary care, out of which the vast majority is spent on curative. That's the problem. So we have to go for more preventive screening as well, to prevent diseases and screen for diabetes. And for this, they are proposing, the Ministry of Health is proposing a cluster system where there are identified primary care hospitals which are attached to a higher level hospital. So it's a matter of putting the systems in place for the investigations, reports to go seamlessly, and the patients could go in their cluster and have a very, I would say, a good or harmonious diabetes care with the PEX clinic and all the associated clinics in that cluster. Then the essential services package of the Ministry of Health has clearly identified as number 3, the NCDs, where diabetes is going to be one of the major things. Then the PSSP project by the Ministry of Health and the World Bank, they are empaneling almost the whole island with the identified local hospital. So that's a good start, I feel. Because you have the data, then you can give them a number and they can be identified, and then we can try these systems on them. and the empanelment, and they do a good work in the healthy lifestyle centers spread out throughout the country. Now I think it's about 1,000, but they are underutilized. So we have to figure out a way how to get the people to come and get themselves screened. So we say above 35 in Sri Lanka, but I would push for about 20, because they say above 35 or 20 to 34 with risk factors. If you look in a family, if there's a first degree family member, you are high risk. So imagine anybody in Sri Lanka is going to have a first degree relative with a 30% prevalence. I think we should bring it down to 20. I think we have to think about it. And with this background, that's the Sri Lanka College of Endocrinologists with the World Diabetes Foundation started the Diabetes Compass project. So this is a digital solution to identify or rectify areas where you can't cover with the existing system. So we need to improve certain processes in the primary healthcare setting. It may be a electronic health record system. It may be an app which can be used by the doctors or the patients. But at the moment, we are concentrating on an app where we could send people, the development officers through the divisional secretaries. We are piloting this in the Kalutara district so that we could go to the houses in the evening and do the screening. So we are developing a diabetes risk score. No interventions at in the houses. They are invited, if they have a higher risk, they are invited to the HLC for further testing. And this is done by the Steno Diabetes Center, and a lot of internationally recognized partners are there for this project, where we are hoping to intervene digitally where things are not happening in the government sector. So I'll give you one example. People are screened in the HLC, pre-diabetic, obese. We have seen many times that book is nicely filled. 2 years later, they come with a sepsis, lost the finger, never gone back to the HLC, full-blown diabetes with a complication. So nobody knew that that person was a pre-diabetic, and they never called them back, although they didn't come. So that's what we are trying to do. The records here, send reminders, develop app or this thing, automatic SMS. Then even if they don't come, in the system, it will flag up. And all those things will connect the Ministry of Health in the form of a dashboard, like the COVID one we are trying to develop, where they will know, even the highest person will know, a particular MOH area, so many pre-diabetics didn't come back for their checkup 6 months later. So that's the system that we are trying to say. It's still cost effective rather than treating diabetes and the complications. So health information, screening and diagnosis, then HCP learning and all these things will be later in the project. So that's about the Diabetes Compass project that we are going to do to improve the care in primary setting. Population interventions is what I am proposing. You can't finish treating all these patients in our clinics. We will run short of time and energy and the medication. Holistic care, multidisciplinary teams should be there, and advocate healthy eating, screening, weight reduction, population approach. If you can reduce the weight of the population by 5%, I think most of these problems can be solved very quickly. And of course, little things that at primary care level that you all can do, those who are working there, stop the smoking, get the blood pressures control. We have all the essential medicines in primary care setting, and correct the dyslipidemia, treat to them. Then we could reduce the cardiovascular risk and the complications of all these people. To do that, I would propose a family approach where culture of exercising, good, healthy diet, all that is inculcated. I think the COVID time, this started a bit, but I think people have forgotten again. So you all have to, those who are working in the primary care setting should think about these things. Very cheap interventions, but that will go a long way, right? If you change the habit of a child, that will go a long way in preventing future diabetes in them. So I always talk about multidisciplinary team. We need the nurses, we need the junior doctors, other specialties, eye, the vascular surgeons, everybody is needed when diabetes needs to be managed in a harmonious manner. This is this is a foreign slide actually, but we need to prepare a similar slide, but you can see electronic medical records and facilitate communication between providers and for registry function. I think that would be the key for us in improving the primary care for diabetes and making it a harmonious setting. So that's it in a 15-minute flash in a nutshell. Those are my ideas. Thank you very much.
Manilka, it's time for audience to ask questions. Since he's the veteran diabetologist in Sri Lanka, please use this time to clarify your doubts.
Anyway, okay, fine. So since you told that its prevalence is going up, is it due to that with the screening methods are very high now because of there are a lot of healthy lifestyle clinics at the moment? And could it be the reason?
Can I answer that? No, yep. The problem is that healthy lifestyle centers, do you know the last 4 years she will know, it's only about 24% utilization. People don't come. That's why we have started this project to go to their houses and try and screen. It's only the elderly ladies and who don't work, 8 to 4 they come, not the high-risk population. The breadwinners of the families, the males, very low percentage.
Yeah,
so I don't think, of course, availability maybe people recognize more and this thing, but I think it's the changing lifestyles. We thought with the economic downturn, there was Dr. Renuka did a study, obesity levels dropped a bit, just last year or so. But the diabetes is rising. Then when I inquired from our patients day to day, so those who are eating plenty of vegetables, they are just having carbs, more starch now. It's all costal, more rice and less vegetables and meat because they are more expensive. Cheap available meal is carbohydrate. So actually the carbohydrate consumption has gone up. So that also may cause, I think it's more than that, it's a few years of dietary habits, sedentary lifestyle, all this culminating in this epidemic or the pandemic. And it's I would call it a diabesity, although obesity is slightly down. The recent STEP survey, I forgot to show, in females, the overweight and obesity was 50% in the government STEP survey. Overweight, above, they took above 27, right? And that's, so diabetes is the main cause, I think, and changing lifestyle.
One more thing, you are talking about the reversal of diabetes.
Yes.
And is it for the pre-diabetics? So it's a group?
Yeah, of course. You say reversal is proper diabetics.
Yeah, and
pre-diabetics, you can do half the job and prevent.
So for that, we must have a very structured way of doing that without telling this and do's and don'ts.
Yes.
And if it is have a very structured way of doing that for the entire country, I think it's a good thing.
So we will work on that. I think easily the healthy lifestyle centers can do that. But I feel those who are pre-diabetic, and then the primary care, the specialized clinics can be for the newly diagnosed ones to work on them to reverse. The pre-diabetics can be easily managed in the healthy lifestyle centers at the lowest level, and if you monitor their weight. And of course, we might need the nutrition support. There are lots of dietitians and nutritionists, being trained. So I think they have to be sent to the periphery. All these places should be manned, not only in tertiary care hospitals. So they have to be sent to the periphery, and of course in the cities, the smaller hospitals. That's where the biggest problem I see. Urban areas, the smaller hospitals have the highest rate of diabetes, and all the dietary the diet is pretty high in the carbohydrate percentage.
Yeah, one more thing, out of all the complications, macro and the micro, what do you, according to your practice, which is the most common, you think?
All are equally common. I mean, if you look at the data.
Because you have not mentioned about the neuropathy,
I didn't want to go through the details. Everything is high in Sri Lanka, so the prevalence, it all depends on the duration of diabetes. So I did the analysis at the National Diabetes Center a long time ago. At the time of diagnosis, neuropathy was about 18%.
So that was my question,
Yeah.
at the time of
even
diagnosis.
at the time of
yes.
diagnosis,
Yeah.
there is nephropathy 15, 18, 20%.
But the neuropathy is very high at the time of
Neuropathy
diagnosis.
is also
That's what-
very high.
Yeah,
Yes, I
that's
get your point. And with the years, depending on the control, that will go up to about 50%.
Yes. Okay, thank you.
Any more questions?
Sir, yeah, this is regarding the diabetes compass you explained, and Mr. Andrews also spoke about the EMR. So was there a specific diabetes risk score developed for the Sri Lankan population like context, or was it adapted like the FINRISC or the IRD, the Indian diabetes risk score?
No, we are doing our own, this thing I didn't mention, maybe Andreas, sorry, I missed that lecture. So we have got 330,000 data from the healthy lifestyle centers and from the Ministry of Health, because they are our partner in this project. We are doing it with the ministry properly. So they have given the whole 330,000 data that they have in the people whom they have screened in the healthy lifestyle centers. So they are, the Steno Diabetes Center is a leading diabetes center in Denmark. So they are statisticians and they are IT people. They are running the data and trying to pick the indicators. So we are looking at the waist circumference, the BMI, blood pressure, all non-invasive measurements, and the family history. With that, they are going to give us an algorithm where when you put that data, that app will show whether there is increased risk or not. So it's a statistically significant number, so they are working on it. Very soon, we'll get our own risk score.
That's amazing. Thank you, sir.